We will now introduce an anchorless technique of arthroscopic transosseous suture rotator cuff repair, abbreviated as ATOS. This surgery is being performed at Matsudo Orthopaedic Hospital since 2005. ATOS uses a unique technique that is as follows. The aiming tip of the Kirschner wire guide is inserted through the anterolateral portal and applied to the medial edge of the footprint. 3 Kirschner wires with perforated tips are inserted from the inferior margin of the greater tuberosity to the medial margin of the footprint. The position of the lower portal is determined using the aiming guide and pilot rod. To avoid axillary nerve injury, a smooth tapered pilot rod is inserted before inserting the wire guide. The first Kirschner wire is inserted by applying the aiming tip of the wire guide to the anteromedial border of the footprint. The second Kirschner wire is inserted to the mid-medial border of the footprint. The third Kirschner wire is inserted to the posteromedial border of the footprint. Now, the 3 Kirschner wires with perforated tips are inserted at the medial border of the footprint. While pulling the rotator cuff outward, the 3 Kirschner wires are threaded through the rotator cuff and then the skin. The rotator cuff stump is pulled laterally. The first Kirschner wire is threaded through the rotator cuff and then the skin. The second Kirschner wire also penetrates the rotator cuff and the skin. Although it penetrates the acromion on the way, this does not cause any problems. This is the third Kirschner wire. Now the 3 Kirschner wires, which have penetrated the greater tuberosity and the rotator cuff, are aligned outside the skin. A nylon thread attached to the 65 cm non-absorbable polyester thread and the 65 cm absorbable PGA thread is passed through the perforated tip of the posterior Kirschner wire. It is pulled out through the lower portal, passing through the rotator cuff and the posterior bone tunnel. The polyester and PGA threads, which have been pulled out, are knotted. The distal part of the PGA thread is cut and pulled upward. Then, the knot is anchored on the lower cortical bone of the greater tuberosity. The nylon loops connected in series are passed through the perforated tip of the central Kirschner wire and pulled out through the lower portal, passing via the rotator cuff and the central bone tunnel. These nylon loops are later used to pass the mattress sutures and the central bridging suture through the central bone tunnel. A nylon thread attached to the 65 cm polyester and PGA thread is passed through the perforated tip of the anterior Kirschner wire. It is pulled out through the lower portal, passing through the rotator cuff and the anterior bone tunnel. The polyester and PGA threads, which have been pulled out, are knotted. The distal part of the PGA thread is cut and pulled upward. Then, the knot is anchored on the lower cortical bone of the greater tuberosity. The blue lines labeled as AB and PB in the schematic view are polyester threads for anterior and posterior bridging sutures, respectively. The red lines labeled as M are PGA threads for mattress sutures. The black lines labeled as N are nylon loops connected in series. The next step is the suture relay. The posterior and anterior PGA threads and the nylon loops are extracted through the anterolateral portal. The PGA threads are passed through the nylon loop and relayed to the lower portal through the central bone tunnel. These PGA threads are used for the mattress sutures. The nylon loop is returned to anterolateral portal. And a 65 cm polyester thread for central bridging suture is relayed to the lower portal through the central bone tunnel. These are the two PGA threads for the mattress suture. These two PGA threads are ligated by square knot using a polyester thread. Next, this ligature is twisted around the mattress sutures and ligated by square knotting. This process is repeated. This knot is inserted into the greater tuberosity and tightened. You will notice that the rotator cuff is drawn laterally by the mattress sutures. In this way, the two mattress sutures are done simultaneously. At this stage, the anterior, central, and posterior polyester limbs for bridging sutures remain above the rotator cuff. This is one limb of the polyester thread for the central bridging suture that passes through the central bone tunnel. Other limb of the polyester thread on the rotator cuff is pulled out through the lower portal along the lateral wall of the greater tuberosity using a suture penetrator. This limb and the other limb passing the central bone tunnel are ligated with square knot using a polyester thread. Next, this ligature is twisted around the central bridging suture and ligated by square knotting. This process is repeated. This knot is inserted into the greater tuberosity and tightened. The rotator cuff stump is pulled to the lateral border of the footprint and then pressed down to it. This is one limb of the polyester thread for the anterior bridging suture that is anchored to the cortical bone of the greater tuberosity. Because the anterior polyester limb for bridging suture use on the rotator cuff cannot be pulled out directly through the lower portal, it is first pulled out through the anterolateral portal. Next, it is pulled out through the lower portal. This limb and the other limb passing the anterior bone tunnel are ligated with square knot using a polyester thread. Next, this ligature is twisted around the anterior bridging suture and ligated by square knotting. This process is repeated. This knot is inserted into the greater tuberosity and tightened. The anterior portion of the rotator cuff is also pulled laterally and pressed onto the footprint. The posterior polyester limb bound to the bridging suture cannot be pulled out directly through the lower portal. Therefore, it is first pulled out through the anterolateral portal. Next, it is pulled out through the lower portal. This limb and the other limb passing the posterior bone tunnel are ligated with square knot using a polyester thread. Next, this ligature is twisted around the posterior bridging suture and ligated by square knotting. This process is repeated. This knot is inserted into the greater tuberosity and tightened. The posterior portion of the rotator cuff is also pulled laterally and pressed onto the footprint. The mattress and 3 bridging sutures are further tightened and secured by 3 half-hitch knots. This is the mattress suture. It is being tightened up. You can see that the rotator cuff is tightened further. After that, it is secured by 3 half-hitch knots.
Next, 3 half-hitch knots are added after further tightening the anterior, central, and posterior bridging sutures.
Here, you can see the 2 absorbable PGA mattress sutures and the 3 non-absorbable polyester bridging sutures. We can easily add extra mattress and bridging sutures placing the aiming tip of the wire guide on the rotator cuff after suturing. We add 2 extra bridging sutures when the AP diameter of the rotator cuff tear exceeds 3 centimeters. Protection of the axillary nerve is critically important in the ATOS, in which the Kirschner wires are inserted through the inferior margin of the greater tuberosity. When the Kirschner wires are inserted from the periphery of the axillary nerve, the bridging suture causes axillary nerve entrapment. The neurovascular bundle can be confirmed by a preoperative MRI image. We take a safety zone of 1 centimeter from the axillary nerve and insert the Kirschner wire 1 centimeter above the neurovascular bundle. The angle between the wire insertion point from the inner edge of the footprint and the straight line perpendicular to the humeral shaft, which is usually 60 degrees to 65 degrees, is the safe wire insertion angle. Post-operative MRI shows that the neurovascular bundle and Kirschner wire insertion point are sufficiently far apart. The axillary nerve is safe as long as the Kirschner wire is inserted proximal to the nerve. The clinical outcomes 2 years after surgery are as follows. The preoperative mean UCLA shoulder score was 19.1, and the post-operative score was 32.7 out of 35, excellent in 55%. Good in 33%, and fair in 12%. Since May 2015, we have been using absorbable PGA thread for mattress sutures. The re-tear rate during this period was 0% for small tears, 2.4% for medium tears, 8.7% for large tears, and 3.1% overall. Benefits of ATOS. 1. Since the ATOS technique only uses sutures, the surgical material costs only $12. Inexpensive surgical material is an enormous advantage of our method. 2. This method has excellent clinical outcomes and a low re-tear rate. 3. Reoperation is easy for the re-tear patients because there are neither implants nor large bone holes in the greater tuberosity. References are shown here. All of them are open access articles. Hence, you can download the full text for free. I would appreciate if you refer these. Thank you for watching this video presentation.